Okay, good morning everyone. Welcome to lecture 52 of BMS 300. So today is part 3 of the urinary system, and what I hope to do is wrap up things as far as new material is concerned in the first 15 minutes, and then the remaining time we'll do poll everywhere questions from the digestive system. All right, and after that I believe that'll take us till the end of the class, and then when we come back on Wednesday we'll do the poll everywhere questions from the urinary system, right? And my hope is by the time you come to class that you've already figured out the answers, and what we're doing in class is just a confirmation of what you already know. All right, so with that, let's get started. Here's an overview of what we'll be completing, right? So we were discussing last week about the 3 steps in urine formation, right? Step number 1 is glomerular filtration, step 2 is tubular secretion, and step 3 is tubular reabsorption. So step 2 and 3 can happen simultaneously. So today what we're going to do is we're going to talk about what are the factors which influence urine formation. Okay, and we see that the volume of urine formed can be altered depending on a few factors. We also talked about the rate at which urine formed can be influenced, and I discussed that briefly about the impact of short-term stress. So I said if you are exercising, then your urinary output goes down, so short-term stress can decrease your urinary output. And then we briefly talked about the impact of long-term stress, right? And I told you about 2 hormones when you have long-term stress, cortisol and aldosterone. And today we are going to focus on how aldosterone can play an impact on the volume of urine being produced, and we'll talk about another hormone, antidiuretic hormone, as well. And then we'll briefly touch upon urine analysis, how the urine can be analyzed to see if there are pathologies in different organ systems. And finally we'll wrap up with the functions of the urinary system, which mainly should be review for most of you because we have briefly touched upon this in the previous weeks. Okay, so now let's move on to the RAS system. It stands for the renin, angiotensin, aldosterone system. Okay, so these first 3 names, renin, angiotensin and aldosterone, they're all the names of 3 different hormones. Okay, and we'll see what their functions are. But before we get to these 3 hormones and how they are produced, I want to draw your attention back to the juxtaglomerular complex, which I mentioned on Friday. So these are 3 types of cells which have different functions. Okay, and the first kind of cell I want to point out is the juxtaglomerular cells shown right here. These are the ones which are lining the afferent arteriole, which brings blood to the glomerulus. So if there is a decrease in pressure in the blood coming to the glomerulus, that will be detected by these cells because they are mechanosensors, and they will cause the release of this hormone known as renin. Okay, so it is these juxtaglomerular cells which produce renin in the nephron. We find that renin can also be produced for another reason, and that is when the macula densa cells, which are in the distal convoluted tubule, which comes in contact with the glomerulus, these are osmoreceptors and chemoreceptors. So if there is a change in the concentration of sodium in the filtrate, if there is a drop in sodium concentration, these macula densa cells can detect it, and that can send signals to the juxtaglomerular cells, which will release renin. So we see that whether there's a drop in blood pressure or there's a change in the concentration of the filtrate, that can lead to renin production. So let's see what renin does. Renin will be released into the bloodstream, and this is going to help in the conversion of this hormone known as angiotensinogen. Notice that this is produced by the liver, and angiotensinogen will be converted into angiotensin 1 by the action of renin. So renin is what converts angiotensinogen into angiotensin 1. Now angiotensin 1 will continue to be circulated in the bloodstream, and when it gets to the capillaries in the lungs, right, the pulmonary capillaries, there is another hormone known as ACE, right? So this is the ACE enzyme, angiotensin converting enzyme, which will convert angiotensin 1 into angiotensin 2. So if I briefly mentioned this when we talked about the functions of the respiratory system, I said that the ACE enzyme is found in the pulmonary capillaries and it can play a role in regulating blood pressure, right? So here is where we are considering this. Now angiotensin 2 has got a number of functions. One of the first things it does is it can act on your brain and it can increase the sense of thirst, so it makes you feel thirsty. That is something which I have not listed here, but we see that angiotensin 2 can act on the blood vessels and it can lead to widespread vasoconstriction. And this is something which makes sense because it was a drop in blood pressure which initially caused renin to be released, and so we see angiotensin 2 is causing vasoconstriction, thereby it can increase the blood pressure as the vessels constrict. Now the second thing which angiotensin 2 can do is it can act on the adrenal cortex and it releases the hormone aldosterone. Okay, and we talked about aldosterone on Friday's lecture. I told you this is a steroid hormone which will go into the cell, it can act inside the nucleus, and it leads to the expression of these sodium potassium exchange pumps. Notice that these pumps are going to be incorporated into the cell membrane both on the apical and the basolateral surface, and this leads to sodium being reabsorbed back into the bloodstream, whereas potassium will be excreted into the tubular fluid to be lost in the urine. And so water is going to follow where sodium goes, and so when you have more sodium being reabsorbed back into the bloodstream, it leads to greater water retention. So if there is more water retention, that increases the blood volume and thereby that will increase the blood pressure. Okay, so this is what aldosterone does. Now angiotensin 2, it's got one more function. It can go to the pituitary gland, and the pituitary gland has two lobes. It has the anterior lobe and the posterior lobe. Anterior lobe will release 6 different hormones. Lucky you didn't get to study all of that this semester, but we will revisit a couple of those in the reproductive system. But in the posterior lobe, there are 2 hormones released. One is oxytocin, which we will talk about in the reproductive system, and also an antidiuretic hormone, which stands for ADH. So the term diuresis means to have increased urine production. Antidiuretic hormone is going to have the opposite effect. It will decrease the urine production. So the way it decreases urine production is by having an impact on water being reabsorbed into the bloodstream. Okay, so we'll consider what ADH does in a second, but I want to briefly mention the 2 different mechanisms by which water can be moved from the filtrate in the renal tubules back into the bloodstream. Right now, the 2 mechanisms are the transport can happen either through paracellular transport. So the term para means alongside. So this is a transport which happens in between the cells, and I told you that these cells are held together by tight junctions, and so these tight junctions have some pores in them which permit water to enter past in between these cells. So this is the paracellular transport. Now the transcellular transport is where water can move directly across the cell membrane, and this cannot happen just like that because we know there is the phospholipid bilayer, and so there are these special transporters known as aquaporins, and that will permit water to move from one side of the membrane to the other. Okay, so here's a cartoon showing you what aquaporin channels look like. They're just going to permit water to enter in, and there are different types of aquaporins depending on which tissue you consider, right? And it's beyond the scope of our discussion to talk about these different isoforms, but I just put up this slide to tell you that things can be more complicated, right? And this is a slide which I have not included because I don't want you to think I will hold you responsible for that. So now coming back to the role of antidiuretic hormone, this antidiuretic hormone will act on the collecting duct of the nephron of this nephron, right? So collecting duct of the nephron is going to be impacted by antidiuretic hormone, and a number of aquaporins will be inserted into this collecting duct. And so notice, due to the action of ADH, more and more water is being reabsorbed back into the bloodstream, and as a result you have the urine volume being decreased and you have very concentrated urine. Is this clear? How antidiuretic hormone helps to decrease the urine volume. Now let's say for some reason you have an inhibition in the antidiuretic hormone, as you see here, right? So we see that the amount of water being reabsorbed back into the collecting duct is much lesser, and so the urine volume will be much larger. And notice that this light yellow color indicates that the urine will be very dilute as well. Are we clear, folks? All right, so let's just tie this back to the renin, angiotensin and aldosterone system. So the reason renin was triggered in the first place was because there was a drop in blood pressure, that was one reason. And so by decreasing the urine output, you increase the blood volume, and thereby you can restore the blood pressure. Is that clear how ADH plays a role in restoring blood pressure and blood volume? Yes? Okay. Now let's come back to the second panel. What can potentially inhibit the antidiuretic hormone, right? So we see that one thing which inhibits antidiuretic hormone is consumption of alcohol. So it inhibits the release of ADH when you have too much alcohol, and as a result you have excessive urination, right? And people who drink too much alcohol go to the bathroom quite often, and so that eventually can lead to the dehydration which is experienced, right? And there will be the hangover effects as well. So this is one case where antidiuretic hormone can be inhibited, excessive alcohol consumption. Now there is another condition known as diabetes insipidus, right? So this is a condition where the ADH levels are not high enough to trigger water reabsorption into the kidneys, and so in such a case there will be excessive urination. You could have even the loss of 20 liters of water per day, right? So there's excessive urination, and the term insipidus means tasteless, right? Whereas the term mellitus means sweet. So if you look at the etymology or the roots which make up these words, diabetes comes from the word diaphrene, which means to flow through. So you have a lot of flow of tasteless urine in the case of diabetes insipidus, whereas in diabetes mellitus you have an excessive flow of sweet urine, right? So that's why these terms diabetes mellitus versus insipidus are used. Yes, and back in the day they would taste the urine to confirm diabetes mellitus or insipidus. All right, so any questions at all, folks? Yes?
So I guess I have two questions. The first being about the diabetes insipidus. Do you just treat it by just constant intake of fluids, or is there any sort of medication that can almost synthetically put in more antibiotics?
I think they would try to deal with the root cause, which is the low levels of antidiuretic hormone.
So you try to just get more of that into the body somehow?
And there are synthetic drugs you could take. Yeah.
And then second question, this has to do with the different aquaporin channels. Are there pathologies associated with the mutations of those particular genes? I know that's completely out of the scope of this class, but
Mutations cause disease, are linked to diseases, so short answer is yes. Happy to discuss it outside class. Okay, great. So now let's talk about how the urine can be analyzed to detect different kinds of pathologies, right? So we find that the analysis of the urine can be done both macroscopically, and there can be microscopic assessment under the microscope, and this is based on some of the characteristics which are analyzed. So we find that urine is made up of 95% water and only 5% solutes, because thanks to the tubular reabsorption, a lot of the solutes are going to be taken back into the bloodstream. So these solutes include urea, uric acids, creatinine, which we'll consider how they get there in the first place. There are also other normal solutes as seen here. So it can be indicative of pathology if any of these solutes are found in a higher concentration than what is normally expected, right? And so the higher volume, higher concentration of any of these solutes, or the presence of any unexpected components can all indicate pathology. And so unexpected components will include blood in the urine, the presence of white blood cells, ketones, proteins, and we'll discuss why these things could end up there in the first place. So we'll talk about some of the physical characteristics of urine, and then we'll see what are the chemical characteristics as well. So in terms of the physical characteristics, which you can just detect even with the naked eye, first is the color and transparency. So we find that if the urine is doesn't have any color, that could be an indication of excessive hydration, whereas if the urine color is very dark, it may be an indication that a person is not well hydrated. We also see some drugs and supplements can affect the color of urine. An example is taking, let's say, B complex vitamins can make the urine extremely yellow. If it's cloudy, it could be indication of an infection. Notice that the odor should be aromatic when it's fresh, and also the pH is slightly acidic. But notice that both the odor and the pH can be affected by drugs, diet, and infection as well. For example, just drinking coffee can change the odor of urine. Or another example is having asparagus in the diet. There are a lot of sulfurous compounds, and that can lead to a very distinct odor of urine as well. So the specific gravity of urine is slightly higher because it is the density of urine divided by the density of water, and we know that urine has 5% solutes, and so we would expect the specific gravity of urine to be slightly higher than water. As far as the chemical characteristics are analyzed, we see that you could use this urinary dipstick, which has a number of patches on it which will react with different components of urine, and it will accordingly change color, right? And so there are a number of things, I believe like 10 different things you can detect using such a urinary dipstick, right? But let me just talk about a couple of pathologies which can be detected using this urine dipstick. So the first one is the presence of proteins, and we know that if proteins are present in the urine, it could be an indication of hypertension, because we see that proteins generally should not be moved into the filtrate because of the small size of the filtration slits. But if there is hypertension, it could lead to these the glomerulus being damaged, and as a result proteins can enter into the filtrate. So this could be the indication of hypertension if there are proteins like albumin in the urine, and albumin is one of the major components of proteins in the blood. And also the presence of glucose could indicate diabetes, because the transport maximum has been exceeded when a person has diabetes. There's high levels of glucose, and so that can end up in the filtrate. Also the presence of ketones. I told you that if the body is unable to move the glucose into the cells because of the impaired insulin sensitivity, the body will start using fats, and a byproduct of fats is the ketone bodies, and when that is being released in the blood, it can end up in the urine as well. And then fourthly, there's a condition known as liver dysfunction, which can be detected by the levels of bilirubin. So we see that when the red blood cells are broken down in the body, you remember the discussion on what happens in the spleen? Yes. All right. So we find that the hemoglobin is the heme group will be further broken down into various compounds, and one of them is bilirubin, which has a distinct yellow color, right? And this is processed mainly in the liver, and if this ends up in the urine, it could be indication of liver dysfunction. So in this case, the urine may be yellow, but also other tissues of the body like the whites of the eyes and the skin can also appear yellow due to the accumulation of bilirubin. Finally, we did talk about urinary tract infection, and this can be detected by the presence of white blood cells or leukocytes in the urine, because these are produced at a higher level to fight the infection. Any questions at all, folks, on how these pathologies are detected? Yes? Okay, moving on to the functions of urine. This will mainly be review, right? So we find that one of the major functions, did I say functions of urine? No. One of the functions of the kidneys is a metabolic function. We know that it plays a role in filtering the urine, but we also find that it can play a metabolic function, and this is explained in the synthesis of vitamin D. Now this is a slide we talked about when we discussed the integumentary system, because the first precursor of vitamin D is produced in the skin, and then this is further processed in the liver, and finally the active form of vitamin D, which is calcitriol, is produced in the kidneys, and this will in turn act on the small intestine to help calcium absorption. Okay, calcium is absorbed into the small intestines. Now moving on, we find that there are three types of metabolic wastes we consider. The first one is urea, and this is produced as a result of protein breakdown. The amino acids cannot, the amino group cannot be used by our body, so it is stripped off and it's excreted in the urine as urea. Now another metabolic waste is creatinine. We talked about the role of creatine phosphate when we discussed metabolism. So for the first 15 seconds when you're trying to do a high intensity activity, creatine phosphate will give the phosphates to ADP to make ATP, and we find that this creatine is mainly stored in the muscle, but we see that around 2% of creatine is going to be lost in the urine as creatinine, and so the level of creatinine in the urine may be an indication of the muscle mass, right, because only 2% of the total creatine in the body is lost as creatinine. We also find that uric acid is going to be produced from the breakdown of nitrogenous bases like the RNA, and other organic wastes will also be found in the urine, and all of this will be dissolved into the bloodstream, and eventually it will be removed when the blood is filtered. And whenever these substances are removed in the urine, there will be loss of water as well, which we find. So moving on to the other functions, we see excretion is a major function, and there's the removal of toxins, metabolic wastes, and also excess ions in the blood. And I want to draw attention to this table here. Notice that the plasma concentration of these various ions and metabolites and nitrogenous wastes are given on the left column, whereas on the right column you have the concentration of these various substances in the urine. So you will notice that as far as the ions and metabolites and nutrients are concerned, the concentrations are similar in both the blood plasma and the urine. However, when you consider the nitrogenous wastes, they are going to be found at a much higher concentration in the urine when compared to the blood plasma. We also find that the blood homeostasis is maintained by the kidneys, and this homeostasis could be through the regulation of the blood volume. We talked about the RAS system. Also the chemical composition can be influenced by tubular secretion and reabsorption, and also the pH can also be maintained in the blood through the function of the nephrons as well. Finally, we see that some gluconeogenesis can happen to a small extent, especially during fasting. We know that gluconeogenesis generally happens in the liver, but even the kidneys can conduct this to a small extent as well. As far as the endocrine functions are concerned, we see that the RAS system begins with renin, a hormone which is produced by the kidneys, and this can help maintain blood pressure in the body. And also erythropoietin. Remember discussing this in blood doping. Erythropoietin is a hormone produced when you have lower levels of red blood cells, and so there are certain cells in the kidneys which will release erythropoietin, and that can trigger the synthesis of new red blood cells. So with that, we're done with the urinary system. Let me summarize. Right, so on Friday's lecture we talked about the medullary osmotic gradient and how that is maintained by the role of the nephron loop, specifically in the juxtaglomerular nephrons, and also the vasa recta as well. Both these play a role in maintaining the medullary osmotic gradient. We also saw how the urine formation can be controlled through the juxtaglomerular complex having an impact on the glomerular filtration rate, and we noticed how short-term and long-term stress can impact urine formation as well. And then we discussed about urine analysis, how the physical and the chemical properties of urine can be examined to determine certain kinds of pathologies in the body. And we find that the urinary system has got influences on multiple organ systems, and it can be influenced by various organ systems, and this is highlighted by the renin, angiotensin, aldosterone system. Notice how many different organ systems are impacted when there is a drop in blood pressure. We also saw the impact of the urinary system in reproductive function, and the role it plays in the synthesis of vitamin D, where the precursors are made in other organ systems, and the downstream effects of vitamin D are seen in various organ systems. So with that, we're done. Are there any questions for me? Okay, if there are no questions for me, let's move on to the poll everywhere question, right? So this is a question we already discussed. After not eating for 4 hours, you see the waiter bring out your favorite meal. This would result in an increase of all of the secretions except which one? A, alkaline mucus? No? No, okay. B? Okay, salivary protein. Why is that? Doesn't exist. Thank you. Ghrelin, yes. Where is ghrelin produced? In the stomach, right, as shown in this slide right here. And lysozymes are produced in the, where's lysozymes produced? It has antibacterial activity. The saliva, right? Yes, excellent. Is this clear, folks? Option B is the answer. Okay, next question. As a bolus of food enters the stomach and causes it to distend, meaning the stomach is stretching, which of the following secretions do you think will decrease? Is it A, mucus, B, hydrochloric acid, C, ghrelin, or D, gastrin? How many of you think it's A? A? Okay, no hands. B? C? Okay, I see a few hands for C, and D? Nobody. Okay, so we see that the right answer is ghrelin, C, because we find that ghrelin is a hormone released by the stomach when the stomach is empty, right? And as the stomach gets full, the ghrelin levels will drop, and ghrelin is known as a hunger hormone. Now the remaining, we find that as the stomach is getting filled and it's getting stretched, we find that gastrin is going to be released to a greater extent. We know that gastrin was released even during the cephalic phase, but as the stomach distends and stretches, it's releasing more gastrin, and it also causes more hydrochloric acid to be produced, and the mucus secretion will also increase as the stomach is stretching as well, right? So the only thing which decreases as the stomach distends is the ghrelin levels, because you're no longer hungry because the stomach is expanding. Is this clear, folks? Yes? Can we move on to the next one? Okay, all right. All right. So I told you to learn this flowchart, and this is based on that. Due to a mutation, John's gastric cells don't release much acid. How would his condition likely affect the intestinal phase of digestion, right? If it cannot release much acids, which of the following are likely? There would be a decreased secretion of CCK, a decreased secretion of GIP, a decreased secretion of secretin, or a decreased secretion of the alkaline mucus. A, B, C, or D? Folks, these slides are on Canvas, right? I uploaded the PDF files, so yeah. What do you guys think? A? How many of you think A? One person thinks it's A, okay. What about B? How many think it's B? Okay, what about C? Okay, a lot of people say it's C, and D. Okay, so the right answer is C, right? And let me explain why this is the case. I told you that as the chyme moves through the duodenum, depending on the composition of the chyme, the duodenum will have certain secretions, and that's what this figure is saying. So if there are carbohydrates present in the chyme, GIP will be released because it stands for the glucose dependent insulinotrophic polypeptide as well. GIP stands for that. Whereas if there is lipids and proteins in the chyme, CCK will be released. But if the chyme is acidic and it has a low pH, then secretin would be released. And the reason secretin is released is it's going to have an impact on the pancreas to release some buffers to neutralize the acidic chyme, right? And we see that if the cells don't release too much acid, right, then we find that there will be a low, the pH won't be as low, and so secretin release will be impacted. Is that clear, folks? Yes? Okay. Question number 4. During swallowing, blank prevents food from entering the trachea. Is it the tongue? Yes or no? No. Uvula is this part here which hangs down from the upper part of the oral cavity. Epiglottis? Yes? Okay, most of you said epiglottis. And the soft palate? No, that's not going to help. So the epiglottis, as you can see here, is made up of what cartilage? Hyaline cartilage? Fibroelastic cartilage? Elastic cartilage? Okay, elastic, yes. So it's going to bend over the opening into the trachea, and so it will prevent the bolus from entering there, but it directs the bolus to move into the esophagus. So the answer is C, epiglottis. Okay, next question. Mastication will enhance the enzymatic action by increasing blank of the ingested food. Is it the volume of the ingested food, volume to surface area ratio, or the surface area, or the surface area to volume ratio, or the density? A, B, C, or D? How many of you think it's A? Okay, B, C. All right, okay, wow, good. A lot of hands. So it is the surface area to volume ratio as shown here. Chewing increases the surface area to volume ratio, and explain that using this figure here. The larger the cube, it has a greater surface area, but if you divide it by its volume, it's pretty small. But smaller the cube, it may have a smaller surface area, but if you divide it by its volume, it will have a high surface area to volume ratio. What is the importance of having a high surface area to volume ratio? Why is it important? Yes? Yes, the enzymes will have more surface area to work on, and so the more surface area available for the enzymes to act on, it will make the enzymatic digestion more effective. Okay, so is this clear, folks? Why answer is C? Yes? All right, let's move on to question 6. Which of the following is a consequence of chronic purging? Is it decreased gastric motility, tooth decay, gastric ulcers, or acid reflux? How many of you think it's A? Okay, one person thinks it's A. What about B? Ooh, a lot of people think it's B. C? And what about D? Okay, so the right answer is B, and let me explain why that is the case. So we find that when a person were to purge, the stomach contents are very acidic, and so when the acids come in contact with the oral cavity, it can cause the calcium to be leached out, and that can lead to tooth decay. Now we find that the gastric motility is not going to be affected because the stomach is lined by the mucus, right? And so the presence of acids in the stomach really won't affect the smooth muscles of the stomach. However, will it impact the esophagus? Yes, because the esophagus doesn't have the alkaline mucus coating it, right? So we find that it can affect the esophagus, but the stomach is not affected. Gastric ulcers are not related to purging. It's related to what? We didn't talk about gastric ulcers. What kind of, yes?
Isn't it like the NSA?
Yes, NSA, yeah.
Drugs and it like causes a damage in like the lining of the stomach?
That is one reason, and what is the other major reason? What is it? What's the name of the bacteria? H. pylori, Helicobacter pylori, right? that can also lead to gastric ulcers. And acid reflux, what is that linked to? Dysfunction of the what sphincter? The lower esophageal sphincter, right? Because that's what keeps it tightly shut, and if it has a dysfunction, it opens, then stomach acids can move into the esophagus and lead to acid reflux. Can we move on, folks, to the next question? Yes? All right. The rate of gastric emptying will be delayed by which of the following? Is it by an increased gastric pressure, a very salty meal, or is it a low fat meal or a low fiber meal? How many of you think it's A? B? Only a couple of people. What about C? And what about D? Okay, this is all over the place. All right. So you need to think about how each of these options would impact the 5 factors we talked about, right? So if we have a low fiber meal, what is it going to affect? Which of those 5 determinants will it affect? Starts with V. Viscosity, right? So we see that the stomach contents will become more viscous the more soluble fiber you have present, right? And so viscosity is going to delay gastric emptying. What about a low fat meal? Which of the 5 parameters will it impact? Fat content. It's going to play a role on the nutrient density, right? So if there's more nutrient density, a high fat meal that would lead to more CCK, that will cause the pyloric sphincter to squeeze, be constricted. But a low fat meal will not have that impact, right? And what about increased gastric pressure? Would it make gastric emptying faster? Yes, it would, because the volume is increasing and that causes the gastric pressure to increase. Now a salty meal is going to increase the osmotic pressure, right? So the higher the osmotic pressure, it would require more water to be drawn into the stomach to offset this increased osmotic pressure, and more water being drawn in will take more time, and so that will delay gastric emptying. Is this clear why option C is the right answer? No, B is the right answer? Okay, great. Moving on, which of the various secretions in the stomach will convert pepsinogen into pepsin? Is it ghrelin? Yes? Okay. What about gastrin? Intrinsic factor? Hydrochloric acid? How many of you think that's the answer? Yes. And it is hydrochloric acid which will convert the pepsinogen into pepsin. And this is something I didn't explicitly say in the slides, but I did tell you how ghrelin can have an impact on increased protein digestion, and how it does that is by increasing the levels of pepsinogen and hydrochloric acid, and so hydrochloric acid will convert pepsinogen into pepsin. So this is something which was not mentioned in the slides, but I mentioned it verbally to explain this point about protein digestion. Is this clear, folks? Okay. Question 9. A mutation that decreases the release of cholecystokinin will most likely result in impaired A. fat breakdown, B. insulin secretion, C. neutralization of the acidic chyme, and D. protein synthesis. How many of you think it's A? Okay, most of you think it's A, and A is the right answer because CCK is going to release bile, which will help in the emulsification of fat, and CCK also leads to the release of pancreatic enzymes like lipases, which helps in fat breakdown. So without CCK, fat breakdown will be impaired, but insulin secretion is dependent on GIP. Neutralization of the acidic chyme is dependent on secretin, as shown here, and protein synthesis is not really linked to any of these options at all. I just had to insert a fourth option, right? Is this clear, folks? Why A is the right answer? Okay, moving on. Eating a high fiber diet will not help to prevent which of the following? Is it A. constipation, B. diarrhea, C. diverticulosis, or D. hemorrhoids? How many think it's A? B? Okay, all right, that's B is the right answer, right? So we find that the constipation, diverticulosis, and hemorrhoids are all going to be caused by hardened stools which are not moving through quickly, and so fiber can help treat all of those. Whereas diarrhea, we find that there's excess water retention due to a number of reasons. In fact, even having too much, having some fiber which is undigested, like in the case of celiac disease, can lead to diarrhea as well. So eating fiber may not be the solution. Rather, you got to have electrolytes and water to replenish that which was lost. Is this clear, folks? Right. So here's a question linking the autonomic system function to what we discussed. So you're driving on the highway and narrowly miss hitting a deer. Which of the following biological processes would most likely occur because of your close encounter? Would there be increased gastric motility? True or false? False. Okay, because you are very stressed out. Increased sweat production? True or false? True. Yes. And what about anabolic reactions? No, you're probably burning a lot of calories at that time when you're super scared. Increased salivary production? So that's why people get a dry mouth when they stand in front of an audience, right? Because saliva production goes down, and so they give them a cup of water, you know. Anyway, is this clear, folks? Why the answer is B, increased sweat production. Okay, moving on. So you do very well on the BMS final, right? And you're enjoying a delicious meal. Which of the following biological processes would most likely occur? Would it be A, salivary amylase breaks down triglycerides in your mouth? True or false? False. Why is it false? Exactly. Very good. So amylase breaks down starch, not fats. Bronchial tubes constrict to cause faster airflow. True or false? False. Why? What would happen if it constricts? Less airflow, right? And then C, secretion by accessory organs are inhibited. True or false? False. Why? Yes, we would have all of these secretions released during the cephalic phase, and as you continue eating, there will be secretion by accessory organs like the pancreas, liver, and so on. The delicious aroma activates the vagus nerve. True, right? So that is correct, as shown here. Vagus nerve is going to be activated. One of the consequences of celiac disease is blank, because colonic bacteria break down the sugars that were not digested and absorbed in the small intestines. So would it be bleeding, constipation, floating stools, or feeling bloated or impaired peristalsis? So this is linking the mechanism of what happens to undigested carbohydrates being broken down in the large intestine. How many of you think it's A, B, C? All right, great. So C is the right answer, because we find that when the colonic bacteria breaks down this undigested fiber, it could release gases which could make you feel bloated, or it can have the gases infused into the stools which can float. Okay, here's another question. Which of the following is a disaccharide? So is it A, fructose, B, sucrase, C, maltose, D, lactose, or do you think more than one answer is right? Which one? E, right? So why is E the right answer? What are the disaccharides? Sucrase is not a disaccharide, it's an enzyme. But we see that maltose and lactose are disaccharides. So folks, don't get tripped over the enzyme versus the disaccharide. AAC ending is the enzyme, all right? So it's clear, folks? So C and D, maltose and lactose, are the disaccharides. Okay, moving on, chylomicrons are produced in the blank. Are they produced in the epithelial cells of the small intestines? Are they produced in the liver, muscles, or adipose tissue? How many of you think it's A? A couple of you think it's A, and as you can see right here, the chylomicrons carries fat from the epithelial cells in the small intestine. So it's just a plain recall question, right? You need to know where these various lipoproteins are being produced. Moving on, okay, this was a slide we didn't cover, right? I was very merciful and took out this mechanism of how atherosclerosis takes place. Okay, question 17. Kwashiorkor is characterized by fatty liver because proteins are unable to make which ones? A, antibodies, B, micelles, C, lipoproteins. How many of you think it's C? Or is it bile? Why do you think the fat stays in the liver? A, B, C, or D? Which one? Okay, some of you said it's C, and it is true. Notice here it says fatty liver is because there's decreased VLDL levels. You need proteins to make the VLDL, and without VLDL, fat can be transported from the liver and it stays in the liver. So the liver gets fatty. Is this clear, folks? Or the option is C? Okay, another question. One of the mechanisms to regulate low blood glucose levels is the activation of hormone sensitive lipase. So what is the most directive consequence of activating hormone sensitive lipase, right? And so you notice that hormone sensitive lipase is in the fat cells shown right here. So do you think it would release fatty acids for utilization in the muscles? Yes, yes, and that is the right answer. It is going to release fatty acids to the muscles. The release of epinephrine, gluconeogenesis, and release of glucocorticoids, it's linked to the other three mechanisms to raise the blood glucose levels if there is a drop. Okay, so this is a question based on this mechanism. Moving on to diabetes, glaucoma and diabetic neuropathy are caused by the buildup of blank in the eyes and nerves. Is it A, glucose, B, advanced glycation end products, C, sorbitol and fructose, or D, plaque? Which one? C, sorbitol and fructose, as explained here. So we find that when sorbitol and fructose are going to be produced inside the cells, they can't leave, and so that offsets the osmotic pressure, drawing more water in, and that can increase the pressure in the eye, and it can also throw off the nerve function as well. Okay, here's a question based on what we discussed today, right? Tasteless urine is a symptom of type 1 diabetes, B, type 2 diabetes, C, diabetes insipidus, or type diabetes mellitus? C. Is it C? Because we find that in diabetes insipidus, what is the hormone which is not being released? ADH, right? And so there is excessive urine which is produced due to increased water loss. Last two questions. Which of the following will increase the sensitivity of the insulin receptors on the cell surface? Is it exercise, insulin injections, a high soluble fiber diet, or is it foods with a low glycemic index? What do you guys think? Is it A, B, C, or D? Or would you put an option E as well, which says more than one answer is right? So as shown here, we see that even a high soluble fiber diet can also increase the sensitivity of the insulin receptors, and that is the reason why A and C would be the right answer. And I told you that the mechanism for why high soluble fiber will increase the sensitivity of the insulin receptor is beyond the scope of our discussion. Okay. So last two questions. Okay, so we have which of the following is an example of complementing proteins? Is it A, peanut butter and bread sandwich, B, cereal milk, C, macaroni and cheese, vegetable and chicken stir fry? A, right? A is the right answer. Okay, last question. Which of the following hormones are synthesized by the beta cells in the pancreas and stimulate the synthesis of glycogen and fat in the liver? Can you shout it out? What does the beta cells produce in the islet of Langerhans? Insulin. All right. Thank you all for your time, and I will see you on Wednesday.